Talk to your broker to get your kind of care.
Now, according to the National Institute of Health, about 70 to 80% of women would have experienced fibroids by the age of 50. Now, some women may not even be aware, that they have them because they don't often cause pain or any symptoms for that matter. But about less than 25% of them will experience symptoms that range from, minor pain, from, occasional irregular bleeding, sometimes to a point where it's so severe that it requires surgery. Now, the subject of our discussion today is uterine fibroids. And to help us understand the subject in a lot more detail, we've put together a panel of esteemed specialists, gynecologists, one a consultant at Charlotte Maxeke Hospital, and the other one at Parklane Clinic. And we also have on our line from Cape Town a specialist diagnostic interventional radiologist, and we also have a famous patient, personality, that has had the problem of fibroids and is going to share that story with us. And as always, you can be part of this show by, asking us a few questions or sharing your views with us. And in that case, the number to call is Johannesburg 714-6841, 6842, or 6843. You can also tweet at SABC Health Talk or simply interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this exciting show ahead. I'm Dr. Selina, and this is Health Talk.
According to the Center for Uterine Fibroids, over 70% of women will develop uterine fibroids at some point, although they only cause symptoms in about 25% of women. Dr. Lusanda Shimange-Matsose, who is a specialist gynecologist working at Charlotte Maxeke, she shared with us how fibroids develop.
Fibroids, to put it simply, are benign tumors of the smooth muscle of the uterus. What that means is that they're not cancerous. Okay, and they're the most common tumors that are found in women of reproductive age, and they're found in about 70% of women, but only about 20 to 40% will really complain of signs and symptoms. So they'll only give about 20 to 40% of women problems, but even though 70% of the reproductive age women will have them.
Fibroids become revealing. They can cause issues like heavy periods, abnormal bloating, sensation of pressure down there, constipation, or painful sex. They can interfere with the woman's daily activity or daily life.
They have different presentations. So what we worry about in terms of fibroids is that patients will come complaining of pain, they'll come complaining of bleeding, they'll come complaining of pressure symptoms if they are very big fibroids, or they'll come complaining of subfertility or infertility depending on where the fibroids are located. The problem with them, when it causes bleeding, then you have a patient who's chronically tired, and it also disrupts their daily life if they have a lot of what we call menstrual blood loss. In terms of pressure, when they grow very big, a woman can actually look pregnant when they've got fibroids, when they grow to that extent. And then they suffer from things like constipation or frequency, meaning they want to urinate all the time because of them putting pressure on the bladder and the bowel.
The biggest point of confusion around fibroids is if women can still conceive if they have fibroids.
It all depends on the patient's age, the patient's desires. When I say desires, so when we look at fibroids, you ask yourself, okay, this patient's got fibroids. So does she desire fertility? In other words, does she desire to fall pregnant? Or she does not desire fertility? She does not desire to fall pregnant. And if she does not desire to fall pregnant, does she desire her uterus? In other words, I want my uterus, or she does not want her uterus. So I always say the easiest patients to manage with fibroids are the ones that don't desire fertility and don't desire their uterus, because that's straightforward. You can do a hysterectomy, which is removal of the womb.
Overall, dealing with fibroids really comes down to knowing what's best for you. It requires a great relationship with your doctor to talk through the different options before you come to one decision. Also, do not be afraid to get a second opinion if you're not comfortable with the information you are receiving.
There are no complications and everything goes well, you're definitely...
All right, here to tell us more about, fibroids, and we're going to learn all there is to know about fibroids. I have two very special guests. On my extreme right is Dr. Selina Ramatsoso, who's a specialist obstetrician and gynecologist based at Parklane Clinic. Welcome to Health Talk, Dr. Ramatsoso.
Thank you very much. Thank you for inviting me.
All right, and next to her is another specialist obstetrician and gynecologist, Dr. Lusanda Shimange-Matsose.
Yes, sir.
She's a consultant based at Charlotte Maxeke Hospital in Johannesburg. Welcome to Health Talk.
Thank you for having me.
All right. All right, I have the luxury of putting the question to either of you.
Yes.
All right, let's start with the basics. Let's understand exactly what this problem is. What are fibroids? Or perhaps just take us through, the uterus or the womb, as it were, and how these things develop. Let's start with you, Dr.
Okay. So, basic definition, fibroids are benign tumors.
All right.
Of the
Now, that's all right. Okay, so benign tumors, what do we mean by...
meaning that they are not cancerous.
Okay.
And they are found in the womb.
Okay.
And as we know, the womb has different layers.
Right.
Right. And they're found in different parts of the womb. So they can be inside, in the middle, outside. Yeah.
Okay. Dr. Ramatsoso, how common are these fibroids? We've just heard that they're not cancer, so maybe that's the good news. We don't need to worry so much about them. But how common are they?
They're quite common, especially in the African, anyone with African descent.
Yeah.
They're more common in your reproductive years. So as soon as you're in your reproductive years, you can go assuming that everything is okay while they're still there and they're growing. So they're usually coincidental findings.
Right.
So you assume that everything is okay, and then you go for a scan, and then we find that you have fibroids. So
right.
in most cases, you wouldn't even know that they're there.
Okay, we're going to come back now to the issue of symptoms and so on. But let's just stick on the prevalence. Now, you say that they're more common in mostly African women, and that in the reproductive years.
Yes.
Let's talk the ages now.
Okay.
What sort of age range are we talking about?
We're talking once you've started your period, meaning fibroids thrive on estrogen.
Mm-hmm.
So what makes them grow is estrogen. So for someone who's just started their periods, we would not necessarily see them.
Mm-hmm.
It's when you now starting having changes around 25, 30 years, then we see that something is there. Because at the end of the day, 2 times more, meaning 2 to 3 times more in African women, that's when things will start. So, 25, 30 years of age, then we start saying, okay, maybe you have fibroids, depending on how the periods are changing or how your quality of life is changing.
Okay. Let's come back to the issue of, you described them quite well, that, they can grow from the wall, it can be inside, it can be outside. What actually happens? Why do we have these things growing?
Well, there's a lot of factors, and like Dr. Ramatsoso said, that they thrive on estrogen.
Yeah.
So you basically get dysfunctional tissue in your uterus, which would not normally behave like normal tissue.
Right.
And then because of the estrogen and the progesterone that we all have in our reproductive age, then they start growing.
Right.
And they can grow to very big sizes, or they can just remain small. And like she says, a lot of women have them, but they may not know. So we know about 70% of the reproductive age ladies have fibroids, but only 20 to 40% will present with symptoms. And that is the challenge about the fibroids.
So I guess it begs the question, who gets the fibroids? Just now we said they're more common in African women.
Yes.
We're not saying that they don't occur at all in other races, but they just happen to be more common in African women.
Yes.
Why is that?
Well, it's all really theories, and a lot of the stuff that they've looked at has been in the States. So we know African American women are 3 times more likely than the Caucasian women.
Right.
And it's just, they've looked at factors. Is it late presentation? Is it access to health care? So there's all sorts of variable factors. And then they've looked at the genetics part of it. So looking at the DNA as to could this be the reason? But what we definitely know, it's theories, and it's what we see and what we practice.
All right. But here in South Africa, what is the problem?
There's no one known cause.
Right.
All we can say is the most likely thing, it could be genetic.
Right.
That if you've had maybe your mom, your aunt, somebody in the family with fibroids, it can go genetic. But in terms of this causes it, we really can't say this particular one thing. So if someone comes in and says, why me?
Yeah.
I'm like, at the end of the day, it could be someone else. So there's you couldn't have done anything yourself mainly to say, I got it because I did this.
Yeah.
So it just happens to someone.
Okay. The only reason I'm bringing this is because, it's out there. It's, I got this from a newspaper article where somebody had a suggestion that a diet could have a role to play in the development of fibroids. Your response?
Yes, okay. There is, like I said, with fibroids, it's so difficult. Like, we can't say, okay, this is why you've got fibroids, like Dr. Ramatsoso said.
Yeah.
And yes, there has been an issue about diets,
right.
And what you
particularly
eat, and smoking.
Particularly about fruit.
About food and
about
so
food.
forth.
Yeah.
But those are all theories, and there aren't studies to say, yes, if you eat this, you won't get fibroids, or you'll prevent fibroids. Or if you eat this, then you're more likely to get fibroids.
Right.
Yeah.
The other issue that I suppose a couple of years ago one picked up was that women who've had fewer children are more likely to have fibroids. Is that correct? And why is that?
Yes, there is a theory that if you have children, it's sort of protective somehow to having fibroids in terms of a long-term thing. Yes, that has been proven somehow that by having kids, you're less likely to have fibroids. On the other side of it is, remember, women are starting to have kids much later in life. So you find that at the time in their 30s, when they're now starting to think of starting families, then we find the fibroid. And that could be the correlation in terms of the ones who've had before might not have had, and now at that time, it's at the peak of their growth. So they're at the peak of their reproductive years, and that's when we pick them up.
All right. Let's talk diagnosis now. People watching this program would say, oh, okay, I hear what they're talking about, fibroids. How would I know that I have fibroids? And should I worry?
So, okay, you either fall into the 20 to 40% population where you'll present with signs and symptoms.
Right.
Which can be bleeding, pain, pressure symptoms,
Yeah.
or infertility, in other words, struggling to have children. Or it could just be an incidental finding where you came for something else,
and they pick
and
up
then
that you
we
have
happen
fibroid.
to do a Sonia on you, and we're like, oh, did you, or you won't know you had fibroids, and then you just tell the patient, no, you've got fibroids, but they're very small. The chances are they're not doing anything to you, and that's why you've actually never complained about them.
All right, okay.
Right.
Maybe just let's take Fezega on the line from Pretoria. Fezega, welcome to Health Talk. Fezega, are you there? Okay, we've lost Fezega. We'll come back to her. All right. The other point was around the fact that if fibroids present in younger women, they tend to be a bit more aggressive and cause more problems. Any truth to that?
It's relative. Imagine if we would assume that the majority will be asymptomatic, meaning they wouldn't have any symptoms whatever. The main thing about, once we know that the fibroids are there, the ones that grow fast are the ones that we worry about. So in terms of over a long time, how would we do? Yes, you'll have to come and we monitor the growth. The ones that will grow much faster in a short space of time are the ones that we really worry about. And that's that less than 1% chance of them being cancerous. But that's so monitoring them is more important. So in terms of, if they're there earlier, yes, there's a longer time for them to grow. Hence, it seems like they're the more dangerous ones.
Very interesting. Okay. Perhaps this is time for us to take a very quick break. And after the break, we'll now learn more about the impact that fibroids can have in anyone's life. And we're joined by another famous personality. Please stay with us.
MedShield, embracing our members in good health since 1968.
It's so good, nothing else can replace just your slightest embrace. And if you only would be my own for the rest of my days, I will whisper this phrase, my darling, c'est si bon.
If we're talking health, then let's talk seriously.
Welcome back. We're talking uterine fibroids, and with me in the studio is our two special guests that we've had, before, Dr. Selina Ramatsoso, specialist obstetrician and gynecologist based at Parklane Clinic, and next to me, Dr. Lusanda Shimange-Matsose, a consultant obstetrician and gynecologist at Charlotte Maxeke, and the lady in the middle, who's just joined us, is Selina Booth. She'll tell her story. Sorry, Sonia Booth. Did I just say Selina? Sonia Booth. Sonia is a famous personality. Some of you watching at home will remember Matthew Booth, the famous soccer player, and she has some relation with Matthew Booth, but she's not here to talk about Matthew Booth. She's here to talk about her story. Welcome to Health Talk, Sonia.
Thank you for having me, doctor.
All right, let's stay with you. You had fibroids. I mean, that's the reason why we have you here. You had uterine fibroids, and apparently you had multiple operations. Just take us through your story. What happened?
2 days prior to me going into theatre, I just started experiencing the worst pain ever. I mean, obviously I've had period pains before, but nothing compared to it. I've had ovulation pains before, nothing compared to it. I mean, think of the worst pain you've ever experienced. That's what I went through, and 2 days later I was in theatre being operated on, and I went through a myomectomy, and I think one of the doctors would remind me of one of the other operation.
Ovarian cystectomy. You said there was a cyst.
And the lap scope, yes.
All right. So you had a series of operations because of the fibroids. Do you remember how many fibroids you had?
I had 4.
4. Okay. And all right, perhaps let's just get a comment from Dr. Shimange-Matsose. But before that, we have Yolande from Limpopo. Yolande, welcome.
Good morning, everyone. How are you?
We're good, thank you. Do you have a question for the specialist?
It's more of a comment, rather.
Sure.
Hi, Dr. Selina. This is Sister Yoli. I'm not Selina Etelbutin, now Charlotte Maxeke. And I highly recommend her, and I would really urge all young ones to actually go in and have their health checked,
Right.
It's twice a year to check up on themselves. So I would recommend Selina because I've worked with her. I've seen how she works with patients.
Okay. Well, thank you very much. Your line, unfortunately, isn't very clear. What we can pick up is a positive for Dr. Selina Ramatsoso, that she does a wonderful job. Well done, by the way.
Thank you.
All right, let's just come back to signs and symptoms. What Sonia just said now, she mentioned pain, extreme pain. Can fibroids give you extreme pain? Or perhaps let's just talk about the typical signs. Just now, I know we started talking about sometimes, they can be asymptomatic, or in other words, where there's no symptoms, it could have minor things. But let's take us through the spectrum of signs and symptoms.
So we always, just to put it simply, in terms of fibroids, there are 4 things that you may or may not experience. Okay, 5 things you won't experience anything. So the first thing is bleeding. Patients commonly come complaining of bleeding, and we know that that's due to where they are positioned. So are they inside the wall of the uterus, or are they inside the muscle of the uterus? Right, that's one. And then there's pressure symptoms. What do I mean when I say that? Pressing on your bladder, pressing on your bowel, and where you suffer with constipation or urinary frequency, meaning you want to go and urinate all the time. Mm-hmm. And then infertility, subfertility. That's also based on where they are positioned. Mm-hmm. And then lastly, pain. The pain that's typical of fibroid uterus is more a chronic pelvic pain. Mm. So a patient will come, I've had pelvic pain for however long, I've taken pain medication, it hasn't helped, and then through a series of examination and investigations, we find that they've got fibroids. Mm. The acute pain that you would get with fibroids is when you are pregnant because of the changes that they undergo. We call that regeneration, that they undergo when you are pregnant. That is an acute pain, and it's very typical of a woman who's pregnant, who's got fibroids, we've actually had patients who say, I don't want to carry on with this pregnancy because the pain is just too much.
Okay. Dr. Ramatsoso, I'm going to ask you about the size of the fibroids in relation to the symptoms. But before that, let's take Sini on the line from the Western Cape. Sini, welcome to Health Talk.
Hi, how are you doing, guys?
Good. How are you?
I'm very good, thanks. In 2015, I had an ectopic pregnancy. I believe it's a pregnancy in the fallopian tubes. It was my first time getting pregnant, and I didn't know that I was pregnant. And then I had the whole fallopian tube removed, and then they discovered that I had a cyst as well. So my question is, will that prevent me for future pregnancies? Because I do want to retain my womb, and I still want to carry children. Like, will it prevent me from having children in the future?
All right, let's hear what the doctors say. Dr. Ramatsoso?
Well, it sounds like she had an ectopic pregnancy. I don't know whether it was ruptured. So what determines a further thing? Her question is, will she be able to fall pregnant? Yes. When we would have an ectopic pregnancy...
She mentioned they picked up a cyst when she was operated for the ectopic.
Yes, that is something that would not... in any way prevent her from falling pregnant. Okay. What would determine whether she'll fall pregnant next is how the state of the other tube, because that should have been mentioned. How well was the other tube, because it's important to know, and what actual procedure was done to take the ectopic out of the other tube. Was the entire tube cut, or was the actual ectopic pregnancy just taken out and some kind of... So the actual procedure would be very important to know, and that's what the doctor who did would at least enlighten in terms of, after the procedure is done, your other tube is good and everything else will be okay. So you'll be able to fall pregnant on the other tube.
All right.
So in
terms
let's
of
get
that,
back
to the original question then. So does the size of the number of the fibroids determine what type of symptoms one is going to have?
Yes.
Right?
That is what changes over time. So if they're quite small, 1 centimeter, 2 centimeters fibroid, size and number is what changes everything. Because as they grow, they can, as she had said, impede or put pressure in surrounding organs and by position. So you can have a fibroid that's just on the outside and that's not in any way disturbing the menstrual flow. As soon as it's inside the lining of the uterus, it starts, because what it's doing is it's competing with the blood supply. So it increases in terms of the lining of the uterus. So the period itself becomes heavy. So the bigger, the more symptomatic. Some people can come with a big tummy. So in terms of what you present with, doc, my tummy just can't tuck in anymore. I feel like my tummy is growing. I feel like I'm bloated all the time. Yep. So size is very important, the position and the number. Yep. So number of fibroids, and those are what impacts in terms of symptoms.
Okay. She mentioned something about feeling bloated. So are there any associated sort of symptoms that can be as a result of fibroids? So in other words, somebody that experiences certain symptoms that may not necessarily be coming from the womb, but perhaps from structures around that may indicate that there's a possibility.
So she mentioned bloatingness,
right,
and then constipation. And the other common one is urinary frequency, wanting to go to the toilet all the time. And the only reason is that the uterus is a pelvic structure. It's in the pelvis. And what's in front of it is the bladder. What's behind it is the rectum. Right. So if they grow bigger and bigger and bigger, then that's where the pressure symptoms would be. But if they go extremely big, now this is when they get into the abdominal cavity, right, then we've got issues of blocking the pipes of the kidneys. So what we call that is hydronephrosis. So that gets blocked because of the pressure symptoms.
Okay.
And then that may have a direct effect on the kidneys themselves.
All right. Sonia, you said you had about 4 operations, correct? Were all of them related to the fibroids? We're going to talk about operations just now, but I just needed to know whether or not all of them were related to the fibroids. Yes?
One of them was related to the fibroids.
Okay, we'll come back. Okay. But before that, let's take Anonymous from Johannesburg. Anonymous, welcome.
Oh, good morning. I've got 2 questions. I wanted to find out, is there any possibility of these fibroids becoming cancerous? Okay. That's the first question. Okay. And the second question, I was told that you can also get fibroids in the ovaries. Is it true?
All right. Thank you for the questions. Let's put it to the experts in the studio.
I'll take the cancer one. So what fibroids undergo what we call sarcomatous changes.
Right.
But that is less than 1% of patients.
Okay. For all intents and purposes, fibroids can never be cancerous.
They can never be, but now and then there has been cases described.
Okay.
And that's why it's so important when you've actually had a myomectomy, we send, even you can see it's a fibroid, but we still send it to the lab
just to be
investigated so that they can say to us, yes, it's a fibroid, or yes, it's a fibroid, but this one's got malignant changes. In other words, it's cancerous.
Dr. Ramatsoso, can you get a fibroid from the ovary?
Maybe we need to understand, if you had that picture, the uterus is what has 3 layers. And there's the muscle layer, there's the lining that we shed when we have a period, and there's a serosal layer on the side. Fibroids grow on the uterus.
And so you never from
they can be close in terms of proximity, and be next to in terms of the ovaries and the tubes are part of the uterus. So in that grand, the ovary is separate, the fibroids are on the uterus.
Great stuff. So on this point, that perhaps it's appropriate for us to take a quick break. After the break, we talk about treatment methods available. Please stay with us.
MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. At MedShield Medical Scheme, we don't just talk health, we do health.
It's early morning at UCT Private Academic Hospital in Cape Town, and 37-year-old Margot Joseph is being prepped for her upcoming uterine fibroid embolization procedure. This is a cutting-edge surgery which is increasingly being used around the world to treat women with uterine fibroids. Radiologist Dr. Gary Sudwarts specializes in this treatment. He offers the procedure at UCT Private Academic Hospital in Cape Town. In Margot's case, one of her fibroids had grown to 9 centimeters in diameter, the size of a large grapefruit or small melon, and was causing her extreme discomfort and severe bleeding. She fears she'll never be able to have children because of the fibroids. Dr. Sudwarts arrives to put Margot at ease.
2 weeks will be back at work without any problem. There's a much shorter recovery than you'd expect after a myomectomy or a hysterectomy, which is another 5-6 week recovery. I will give you antibiotics in the procedure.
Margot is a pediatric nurse and has been part of medical procedures many times before, just not as the patient.
Well, when you're at the other side, it's not easy. And you're the receiving side, yes.
Yeah. Right, so the procedure itself is about an hour. You'll be back in the ward about an hour and a half. So I think we're ready to take you to this. And then you can change into muscularis, and the next time you see me, I'll be all in green. Okay?
Thank you, Doctor.
fibroids contain a large number of blood vessels and draw a great deal of blood into them and therefore into the uterus. Added to this, they also stop the uterus from clamping down to stop the bleeding that occurs as part of a normal menstrual cycle. That's why women with fibroids can bleed continuously, so much so that it can become life-threatening. It's 2 days later, and we catch up with Margot before she leaves the hospital to see how she's doing.
I'm doing very well for the second day post-op. And in 2 weeks' time, I can go back to work. So it makes my life so much easier. So for me, this was the best option. This is such a huge thing for me. And I'm so happy because when I found out I had fibroids, I thought that there was no chance that there was to have future pregnancies. So the doctor gave me really hope, and doing for this procedure gave me that option. That is it was such a relief for me.
Welcome back. So if you've just joined us, we're talking uterine fibroids. And with me in the Johannesburg studio, I have Dr. Selina Ramatsoso, who's a specialist gynecologist and obstetrician based at Parklane Clinic. And next to her is Sonia Booth. Yes, Sonia, not Selina. Sonia Booth, who is a recovered patient who had fibroids before. And it's a pleasure to welcome from our Cape Town studio Dr. Gary Sudwarts, who's a specialist diagnostic and interventional radiologist. Quite a mouthful. Welcome to Health Talk, Dr.
Good morning,
Sudwarts.
sir. Thank you for the opportunity. Hi.
All right. We obviously saw in the clip that we played just now that talks about embolization and being a form of treatment that you specialize on. If you don't mind, we're going to come back to you just now because we'd like to know a little bit more about this, form of treatment. But perhaps let's start with you, Dr. Matsose. Let's talk about what treatment methods are available for fibroids.
Okay. The main reason that we treat is to improve quality of life and to remove the symptoms. So you can have medical treatment in terms of not invasive treatment. We start, if you're bleeding, how do we reduce the bleeding? If your issue is pain, how do we control the pain? Right. So most people assume fibroids is automatically a surgical, you have to automatically be operated on. It depends on the symptoms you present with, and the aim of treatment is to alleviate those symptoms. So if you're having bleeding, we're trying to find, you can use low-dose estrogen pill, contraceptive pill, in terms of decreasing. Those have been said to work. There are other modes of treatment that theoretically would decrease the estrogen in the system, but the issue with that, the side effects are quite bad. In terms of they would give you hot flashes, and although it's short term and reversible, but those were the reasons. So medical treatment is there. Then we start talking about if medical treatment fails, so what do we go next level? Then we're starting to talk about myomectomy. And myomectomy is removal of the actual fibroids on the uterus. So the uterus stays behind and we remove the fibroids. And these are very important in people who are still trying to fall pregnant and who still want to increase the number of babies.
It's good you mentioned that because here's somebody who underwent myomectomy. I'm going to come back to you just now to tell us about what you actually went through. But before that, let's take Palesa on the line from West Rand. Palesa, welcome.
Hello.
Yes, ma'am.
Oh, thank you so much. How are you guys?
We're good, thank you. Your question or comment?
Okay, I would like to comment because since 2012, I've been trying to conceive. Yes. And then in 2015, my gynae booked me for a laparoscopy, only to find that I have fibroids and endometriosis. So already I had 3 laparoscopies. So on the 16th, I'm going to do myomectomy to remove my fibroids. I would like to encourage young people, young girls there, to go and check themselves because you come that at a later stage you are able to get pregnant only to find out that you've got a problem. Already I'm 34 and I don't have children. So really I would like to encourage them. This is really important to take care of yourself and do the best for your health.
All right. Thank you for that positive call. I'm sure you'd agree with that, isn't that so?
I agree fully. I think that attitude should change, that you only go see the doctor where there's a problem. You know, people only come and say, why would I go see a gynae if there's a problem? It's actually important to get a clean bill of health, to say, you've had your pap smears normal, we've checked everything, you're on good contraception that fits you, and everything else is fine. So we would have included the ultrasound, and that should be okay. So
Great stuff. Before we cross to Cape Town, let's hear about what you went through, myomectomy. What actually happened?
I mean, one of the fibroids was bigger than the three. It was just a little bit smaller than a golf ball, so you can imagine the size. And I actually had the pleasure, I don't know if I should say that, of actually seeing it, because I was curious as to what they looked like. But 2 days after experiencing those pains, I went through myomectomy. Unfortunately for me, I also had a burst cyst. So I had a lap scope as well, and 3 days later I had a bowel obstruction, and that landed me in ICU. So
Tell us a little bit about, you landed up in ICU. I see that you have a book. Tell us about the book. What's the book about?
Surviving ICU is a personal memoir based on my experiences, because I mean, it's one of those things. You don't think it will happen to you, and you actually feel sorry for you, and you ask, why me? And then you made a good point earlier that why not you? It can happen to anybody. But it gave me an opportunity to write a book so that I can warn other women out there, like the lady caller who phoned in just now, to warn women that, don't just wait for pain to go and see your gynae. At least once a year, check, just to make sure that you've got a clean bill of health. But more importantly, you need to know your body.
Okay, great stuff. Let's cross over to Dr. Sudwarts. Dr. Sudwarts, perhaps let's firstly start by just checking with you. We know radiologists to be people that, take, for putting it simply, taking x-rays and interpreting x-rays. Of course, they do more, we know that. But just tell us how you get involved in treatment of fibroids.
Sure. So it was a bit of a journey for me. Radiologists, as you know, report x-rays, MRIs, CAT scans. But there's a special field, a very large field of radiology, which is interventional radiology, whereby we perform procedures through the skin or through the artery or the vein, accessing organs by that means. There's a very wide range of organs and conditions we could treat, from cancers in the liver or bleeding in the kidneys, all the way to uterine fibroids. And what's happened in my career is I found that there's a very large group of women with fibroids that need a microinvasive option, a so-called non-surgical option, where we could treat the fibroids, giving them the same benefits as a large operation. So this is much less complication, much faster recovery.
This is the embolization you're talking about, yeah?
That's correct.
Yeah, we see, this appears to have revolutionized treatment of fibroids. Is it something new, perhaps?
So I wouldn't say it's new. It's been around for about 30 years. In South Africa, it's only recently that people have started asking for it and questioning whether it would be applicable. Also that the medical aid should pay for it. So this has been relatively slow progress in South Africa, but it's really not new. There are probably 30,000 of these being performed every year in the US. It's well established in large scientific bodies. And the results are long term. With 30 years of follow-up, you can really tell someone what's likely to happen in the future.
All right. We're going to come back and talk about issues such as access and so on. But before, let's take Sebenzile on the line from Soweto. Sebenzile, welcome.
Thank you. Yes, I have a problem here.
Yes.
I was told I had fibroids, and these fibroids were smaller, and they wouldn't do any harm to me. But then as time went on, I could feel the pain, and whenever I menstruated, I had these severe menstrual pains, and above all, I would bleed abnormally. This abnormal bleeding has irritated me for some time. So I told them at Para that I prefer to have a hysterectomy. I have 3 kids, I'm done. I was 47 then.
Yeah.
I'm 52 this year. So I told them I want to have a hysterectomy done. They kept on postponing and checking. They told me I don't need a hysterectomy. And whereas when I have to menstruate, I have these severe pains. So I decided to have first of all, this doctor suggested I have this depot given to me. They gave me a depot and I stopped menstruating for the first 3 months. And then that was it.
All right.
Then the periods came back.
Okay.
Now I decided I better go and re-register at the clinic to have a depot given to me to avoid this pain. That is how I'm healing myself, because they cannot help me. And I even felt, you know what, to have a medical aid, it's no longer a want, it's a need. Because if you don't have a medical aid, the provincial hospitals don't treat us well.
All right. Thank you very much, Sebenzile. Excellent call. Many issues there to address, but I'm going to suggest that we address those after the break because, you know, we've run out of time. But before we do that, Sonia, just in 30 seconds, your last message to women out there watching this program.
Know your family history, because in my case, I only found out 2 days before the operation that my grandmother had fibroids. And you mentioned genetics could be at play, and be informed. If your body is changing drastically or you're experiencing pain that's unusual, don't wait. Go to your gynecologist and have it checked out.
Very profound. Sonia Booth, thank you very much for your time.
Thank you very much, Doctor.
All right, folks, we're going to go for a quick commercial break, and after that, we continue our story on treatment of fibroids. And yes, we'll respond to some of the points that Sebenzile made. That after the break. Please stay with us.
MedShield, embracing our members in good health since 1968. If we're talking health, then let's talk seriously. MedShield Medical Scheme doesn't just cover you when you're ill, we'll help you stay well. At MedShield Medical Scheme, we don't just talk health, we do health.
Welcome back. We're still talking uterine fibroids, and we're talking treatment of uterine fibroids. And I have my special guests. We welcome back Dr. Lusanda Shimange-Matsose, Specialist Gynaecologist and Obstetrician based at the Charlotte Maxeke Hospital, and Dr. Selina Ramatsoso, Specialist Gynaecologist and Obstetrician based at Parklane Clinic. And of course, in our Cape Town studio, Dr. Gary Sudwarts, who's a diagnostic and interventional radiologist. Before I go to Cape Town, because I do want to talk about access and price of embolization and so on, Sebenzile called us, gave us a story around the fact that, you know, she's struggled with fibroids over a period of time, and she's been to a public institution where hysterectomy, I mean, she's a typical story. In your clip, you said that, look, does the woman desire the uterus or not, and that sort of thing. She's had her 3 children, but the hysterectomy is being postponed continually, and then she talks about issues, you know, around bleeding and the depot. I'd like both of you to please comment. Yeah.
I'm not so sure. I didn't really get her age, but
she's 47.
47, and she's completed her family. Right. You know, I always say those patients are the easiest patients to manage when. If you have fibroids, because they'll tell you, I've had my kids and my womb is just causing me so much problems, please take it out. And which is fine. But before we actually do take out the womb, especially if you're above the age of 45 and you come in complaining of what we call abnormal uterine bleeding, we still need to investigate that there's no cancerous cause for the bleeding. So you'd have to go through a series of investigations before we decide, okay, fine. So there is no cancer, yes, we will do the hysterectomy. So, yeah.
Well, in this case, I feel sorry for her because I think we could have somehow made it a quick. She could have been explained to that the aim of the depot, because she says she got the depot injection, is to make sure to alleviate. Remember, there's medical ways of treating it.
Yeah.
So her issue is I'm bleeding immensely. So they gave her the depot to stop the bleeding.
Yeah.
So that
Maybe
the
she still had the
symptoms
pain.
Maybe, do you see? But then I think no one actually explained to her that the aim here is for the symptoms to go away while your uterus is still there. I don't know the size. I don't know whether they're causing anything. We just know that there's bleeding. So she was given something to stop that with the aim that that's the prolongation of the situation instead of opting for more invasive thing like a myomectomy that can lead to, so there's still other ways. You could have had an intrauterine contraceptive device that actually stops the bleed. So the follow-up was very important in this particular case.
Right.
If she had known that she had to continue a bit longer with that aim, and if things change, then that's the next level.
Great. Let's cross over to Cape Town. Back with you, Dr. Sudwarts. This procedure, embolization, obviously we're seeing that more and more of it is being done throughout South Africa. What is the cost of the procedure?
So just also just touching on your previous points, the lady who completed her family with very, very symptomatic, and I think basically she's been let down by the state system. Through communication and access, and she's suffering terribly. The treatment that's been offered to her has had limited result, and she's desperately seeking an alternative. She's a very, very common problem, and we're seeing a lot of women just like her. And that's why actually the procedure that I'm performing is done in the state hospitals. So I'm training registrars or trainees in radiology to perform the procedure. I performed the procedure for several years at Baragwanath Hospital until I moved to Cape Town, and I go backwards and forwards just promoting this. Now, I think it stems from a few problems. One is, there's a large waiting list of women waiting for hysterectomy in state hospitals. Gynaes are under a lot of pressure. There a limited number of them in the state hospitals with a huge burden of patients. This is the kind of procedure whereby we can offer a patient like her an overnight hospital stay, an embolization in a state hospital, and she'd go off and live absolutely normal life with the uterus, but with no bleeding.
So access obviously isn't then a problem. So what's the sort of typical woman where embolization would be indicated on? Or would you do it on everybody?
It started off with, well, you wouldn't do it on everybody. So there's certainly, when people started embolizing, we excluded certain populations from the groups because you wanted to be safe. So we said, look, we don't know its long-term effects, or we're not sure what happens to the particles over long-term, and so on and so forth. So it started with restricted populations of patients, and it's continued to grow over the intervening years. So we started excluding patients originally, had very large fibroids or pedunculated fibroids or fibroids inside the uterus. This has actually turned out to be not true. Very, very large fibroids respond incredibly well. Fibroids that are pedunculated also respond. There is an issue of fertility, which has not been resolved in the medical literature. And that's you've got to be a little bit careful about, because if a gynecologist can do a myomectomy easily, a couple of fibroids, they're easily accessible, and leave the patient without the fibroids within the uterus, or time is a factor, then a myomectomy is considered to be the best approach at this point. We don't have evidence for the embolization. But having said that, there are a large group of patients who are not appropriate for myomectomy. And I've currently got 2 patients who are pregnant who've had embolization. So embolization is definitely an option in women who want to fall pregnant. But I think the first option there would be the myomectomy.
All right. Yeah, unfortunately, we're running out of time. Just a quick one. Obviously, every operation has, side effects and so on. But firstly, who's a candidate for hysterectomy? Who's a candidate for myomectomy? Very quickly.
So we'll start with hysterectomy. I don't desire fertility. I don't desire my womb. I've completed my family. Myomectomy, I'm still in the reproductive age. I do desire fertility.
Right.
Or I'm not in the reproductive age, but I want to die with my womb.
Just to add to that, in terms of hysterectomy, if ever maybe accompanied the fibroids, that the cervical changes that need to be, the uterus need to removed in its whole entirety, or we've said nothing works and this is our last option. So the invasive thing is the last option.
Ladies, it's been such an insightful discussion. I certainly learned a lot, and I'm sure our viewers have learned a lot. Dr. Selina Ramatsoso, Specialist Gynaecologist, Obstetrician based at Parklane Clinic, Dr. Lusanda Shimange-Matsose, Specialist Gynaecologist and Obstetrician based at Charlotte Maxeke Hospital. Thank you so much for your time, and of course, in Cape Town, our studio, in our Cape Town studio, Dr. Gary Sudwarts, Specialist Diagnostic and Interventional Radiologist. Thank you for your time. Right. Guys.
Thank you very much.
Unfortunately, that's all the time we had for you today. Remember, join us again next week, same time, SABC News. Yes, continue sharing those views with us on our Facebook page and send us those tweets as usual. And remember that this show is repeated every Saturday at 2 p.m. and Monday morning at 5 a.m. Thank you so much for watching. My name is Dr. Selina, and as always, thank you for your calls, and yes, continue sending those tweets. Take care.
MedShield, embracing our members in good health since 1968. SMS MedShield to 33023 or talk to your broker to get your kind of care.